Welcome everyone to our last QES webinar of the fall term. We're coming to you from the McMaster Health Forum at McMaster University in Hamilton, Ontario. I will give you a quick rundown of the McMaster Health Forum, our scholarship program and our new scholarship program, and then I'll turn it over to our two Queen Elizabeth Scholarship presenters today, Fanny and Mijia, who will tell you about their experiences in Australia and Uganda respectively. The McMaster Health Forum aims to be the leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, and prepare action-oriented leaders to act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program hosted by the McMaster Health Forum is called Strengthening Health Systems. Our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. Our old QES program is now ending. Mijia and Fanny, who are presenters today, both come from that older program. We now have a new program. We are one of 20 Canadian institutions to be given a new QES program that will run from 2018 to the end of 2021. Our new program is called Queen Elizabeth Scholarship Program in Strengthening Health and Social Systems. And because of the slightly new focus, there are a few changes to our new program, so I'll just point those out to you now. First of all, the location of the internships has changed. Before, we could only send students to Commonwealth countries. That has now been expanded to include Commonwealth Plus, low and middle income countries. Because of this, our partners have also changed. So our partners from our old program are carried over to our new program, but we now have new partnerships in Colombia and Lebanon. And the focus of our internships have changed slightly. We have now added social systems as one of the focus of our internships. And because of that, our eligible programs have changed slightly. So all of the graduate and undergraduate programs that were eligible before are still eligible, but we have now added the undergraduate program of arts and science. And the number of opportunities has decreased. In our old program, we sent abroad or hosted 61 scholars. In this new program, we will send abroad or host 24 scholars. In terms of our old program, they were divided into 3 cohorts. Our first cohort primarily went away or visited us in 2016. We had a mix of incoming, outgoing scholars and interns. In our second cohort, primarily visited us or went away in 2017. You'll see that we had primarily, most of them were made up of 20 outgoing interns. And our third cohort, of which Fanny and Mijia were a part, primarily visited us or went away in 2018. Here we had a large group of incoming scholars who visited us in the summer of 2018 and 15 scholars who have gone abroad during this year. I'm pleased to present our next QE Scholar presenter, Mijia. She is currently an undergraduate student in the Bachelor of Health Sciences program here at McMaster, specializing in global health. She's interested in building the capacity of health systems to support the integrated needs of vulnerable sectors such as immigrants and seniors. And through her internship, Mijia hoped to gain insight into theoretical foundation behind knowledge translation activities, as well as how academic and policymaking institutions can work together to affect change in a health system. Mijia was our first scholar to go to Uganda to work with one of the forum's key partners at Makerere University. So we're looking forward to hearing what Mijia has to say. So here we go, Mijia. So advance talk.
Like this? Okay. Cool. Hello, guys. Thank you, James, for that introduction. Can everyone still hear me if I put it on the table like this? Is all good? Okay, cool. Hello, guys. So, yeah, I guess I wanted to start by doing just a land acknowledgement and talk about how we're kind of gathered here to do this presentation on traditional territories shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, and that sharing of land was acknowledged in like the dish with one spoon wampum agreement, and the wampum uses that symbolism of the dish to represent the land and the spoon to represent the fact that everyone are to share the resources of the land and only take what they need. And that's kind of a great reminder for us to kind of respect the land, use it sustainably, and kind of respect its Indigenous ownership. And I hope I don't sound performative in doing this acknowledgement. I actually think this idea of recognizing that we live on colonized stolen land is extremely relevant when we're discussing like traveling and global health in general for that matter. After all, as an immigrant to Canada, I carry this title of being a colonial settler. And it's with that title that I traveled to Uganda, a foreign African country that has a very long and very complicated history with British imperial rule. And I was also funded by a scholarship that was literally called the Queen Elizabeth Scholarship. And although these details and titles may seem minor, I think it's important for me at least to kind of contextualize myself in that way and recognize the systems of power that are inherently at play when a Westerner like myself enters foreign, previously colonized land to engage in the project of quote-unquote globalization or knowledge exchange. And throughout my trip, it was very apparent to me the privilege that I kind of held in my title as being this quote-unquote scholar from Canada, not to mention like my complexion and all the rest of it, obviously. But yeah, it was also painfully apparent to me the impact of historical and present-day processes of colonization that's left such a proud and vibrant country like Uganda systematically dependent on westernized culture and goods and governance structures and health resources. Much in the same way that Indigenous folks in Canada are subjected to processes of cultural erasure and assimilation, oftentimes without their best interests in mind. And so throughout my trip, I couldn't help but wonder if I was perpetuating this system. And even though my role was only that of a visitor and a learner, this is something that I'm continuing to think about and unpack even like to this day. And I'd love to kind of talk about it more in the question period too, if anyone's kind of wondering where I'm at with thinking about that. Yeah, so I guess all of this is to say that as a scholarship that champions this concept of global discovery, we should understand that we're kind of outsiders operating in an inherently colonialist world that continues to oppress people who are more indigenous to like the land that they're born in. And as somebody who aspires to go into the global health field, I try and integrate this understanding of my own like positionality and power into my practice of being like culturally sensitive and ethically minded, especially when I go on trips like the Queen Elizabeth Scholarship. And that's something that I hope we can kind of all keep in mind as I go through the rest of my presentation. And so, is it this button? Oh, there. So with that said, I guess I just wanted to begin with just some basic like background information that I learned about Uganda when I was there. Uganda is a landlocked country in sub-Saharan East Central Africa, neighboring Kenya, South Sudan, Congo, Rwanda, and Tanzania. It's a nation of 41 million people, where 84% of that population lives in rural areas. It's divided into 121 districts, each with their own kind of government, and in one capital city, Kampala, where I went for my trip. These districts are kind of further divided into counties and sub-counties, parishes, and then villages. And this kind of a decentralized structure is to ensure that resources are kind of allocated fairly to every village. Now, parallel to this state governance structure, Uganda also hosts 5 subnational kingdoms that operate through a constitutional monarchy, the largest of which is the Buganda Kingdom, which spans most of Uganda's central region. And it's actually how Uganda got its name. So Buganda, like the kingdom Buganda in Swahili is Uganda. And Buganda culture and language is still very largely like present and dominant in the region today. So a lot of the folks that I ended up working with spoke Luganda as their mother tongue and identified to have their cultural roots in the Buganda Kingdom. On a more personal note, Uganda for me was a combination of some of the kindest and warmest people, and obviously the most remarkable kind of natural views as well. Uganda was also a lot of firsts for me. I mean, it was my first time spending an extended period of time in a foreign country, falling in love with a university campus that is in McMaster, celebrating Easter with a different family other than my own. ziplining through rainforest, bungee jumping from the source of the Nile, whitewater rafting, finding out where like coffee really comes from, and like just so many things, so much more. In Uganda was also the kind of first time that I was studying a health system, or kind of trying to understand a health system that was outside of the Canadian context. So I kind of wanted to first give an overview of that before I dive into talking about what I actually did. So healthcare in Uganda functions on a referral basis. For somebody living in like a rural community, their first point of contact is a member of the village health team. And if that concern can't be addressed at that stage, then they're kind of referred upwards to like level 2 health centers and level 3 health centers and so forth. So at the top of that chain of referral are national referral hospitals. Uganda has 2 of these, and they're both in Kampala, the biggest of which is Mulago Hospital, which, yeah, like I said, is like the biggest in the country, and it's also a teaching hospital of Makerere University, where I spent my placement. And in fact, my office was located right beside Mulago Hospital, and I was also kind of directly being supervised by the former dean of Makerere's medical school, Dr. Nelson K. Sewankambo. And so I had a lot of these like inadvertent ties with Mulago Hospital despite not having worked there. And in that respect, I felt like I was really lucky to be a health systems researcher with access to the medical institution where there's the bulk of the country's like health resources and medical talents and research efforts, and where all of that was concentrated. So as I kind of talked a little bit about earlier, a lot of governance and decision-making in Uganda occurs at the district level, and that's obviously no exception for the health system. Each district has their own general hospital and all the lower, like subsequent levels of health centers that feed into that general hospital. And each district is also responsible for making their decisions, a lot of decisions regarding like health systems, health services delivery, from human resources to monitoring and evaluation to budgeting of essential medicine. A lot of these decisions are headed by the district health officer of each district. And of course, the priorities and policy guidelines that these district health officers follow are set by the Ministry of Health, which is a body of the national government of Uganda. Kind of unfortunately, I guess, I had to have my own brush with the Uganda health system after an afternoon of like exploring the city and recklessly eating all of the delicious street food that was offered to me, as I was advised against. I developed a high fever in the 40s and all of the lovely signs of bacterial gastroenteritis. That's actually literally a picture of me like the day before that happened. I'm like eating this corn, and then that night I like felt really, really sick. So after a few days of being sick and absolutely terrified, I finally agreed to be taken to a hospital. And I was taken to a hospital called The Surgery. It was this posh westernized clinic that was specifically designed for travelers seeking medical care of quote-unquote international standards and who are like willing to pay out of pocket. So when I asked my coworkers why I shouldn't be taken to Mulago Hospital, which was literally like down the hall from my office, sorry, not down the hall, down the street from like my office and where I lived, my coworkers kind of didn't even entertain this idea of taking me to a government-funded hospital when better options were kind of accessible to me. And sure enough, after a couple $100s and a course of antibiotics, I was good as new. But what became apparent to me in that incident is that healthcare systems where public and private healthcare providers kind of coexist in those kinds of places, disparities between their standards of care can be very, very apparent. And one of the roots of the problem of health disparity is the fact that evidence-based best practices are often not standardized and mandated by the Ministry of Health. So in recognizing that to be a problem, there's been a push in the past decade towards introducing more evidence into policymaking processes, especially in lower and middle income countries. And one of the ways in which this concept is kind of operationalized is through EVIPNet. EVIPNet stands for Evidence Informed Policy Networks. It's essentially this series, it consists of this like series of country or regional knowledge translation hubs that are designed to fill that knowledge to policy gap for that particular region or that country. My host organization was basically one of these hubs. It was called the Regional East African Community Health Initiative, or REACH for short. And it's essentially a WHO-funded knowledge translation platform that's a part of UVipNet that operates out of Makerere University and services the countries of Kenya, Tanzania, and Uganda. So much like the McMaster Health Forum, REACH produces outputs like evidence briefs and rapid synthesis and clearinghouses in order to ensure that health policies and decisions made in these countries are substantiated by sufficient and quality research evidence. At the same time, I wasn't really working within REACH. What made my QUS experience or placement maybe a little bit unique or different from the others was that I wasn't really assigned to one or more kind of projects within my host organization. Instead, I was kind of evaluating the organization itself. So let me backtrack a little bit. The problem that REACH kind of encountered in its earlier years of operation is the fact that African health systems lacked the experience and existing infrastructure to meet the goals of evidence-informed policymaking. So in 2008, the European Commission funded a new program called Supporting the Use of Research Evidence for Policy in African Health Systems. It's a long name, but it's known as SURE for short. And this program was kind of designed to bring partnering organizations from Norway and France and Sweden and Canada to support African countries to do this kind of evidence-informed policy development work, including the work that REACH was already doing. So this is actually one of the ways in which like the McMaster Health Forum became a really strong and long-term partner of REACH. However, despite this kind of international collaboration, one more problem kind of remained. These African countries that were a part of REACH and SURE, they still lacked local capacity. They didn't have the researchers and policymakers and academicians with that KT expertise to do that work without being dependent on European nations and Canada. So this inspired yet another program that was designed to build that local capacity, spearheaded by my supervisor in Uganda, Dr. Nelson K. Sawankambo, and our very own Dr. John Lavis, and through funding obtained from the International Development Research Center, IDRC, they kind of established this new program, this Research Chairs Initiative, to train KT experts and host capacity building workshops in KT, specifically in Africa. So for me, I was kind of actually tasked with evaluating how this program had been like successful in building that local capacity that it wanted to build. And through that work, I would obviously be indirectly supporting the work of SURE and of REACH. More specifically, a part of that IDRC program was supposed to support 5 African PhD students in completing their doctoral training in studying knowledge translation as an actual kind of field of inquiry. So the goal is essentially to ensure that high-level KT experts exist in Africa and are able to guide the direction of evidence-informed policymaking in the future. So each of these students were co-supervised by John Lavis and Nelson, and they got to complete several semesters of coursework, both from McMaster University and Makerere University. They got to kind of network and work with this cohort of these 5 students, and they actually got to also work on the ground with existing KT projects like REACH and SURE. And their final thesis is to embark on kind of an in-depth exploration of one aspect of KT science. So some looked into like rapid response synthesis, others looked into clearinghouses, et cetera, et cetera. So my job was basically to answer the question of whether this doctoral training program or doctoral training programs like this one are productive and worthy of continued investment from funding organizations like the IDRC. And I kind of approached this evaluation in 4 steps through a multi-method approach. First, I went to the literature and looked for any kind of published evaluation of doctoral training programs in knowledge translation that were similar to the one that I was about to conduct. Then I designed, carried out, and coded semi-structured interviews with each of these 5 doctoral trainees and people that they've learned from or worked with or taught about their experiences with the program. Then I took inventory of all of these students' outputs from like published papers to grade-lit to presentations and workshops that kind of arose from the training that they were doing. And then finally, I took these preliminary findings to the funders and the founders and administrators of this program in a focus group setting in order to get their insight and commentary on the preliminary findings on that I kind of got. Obviously, a lot of like really interesting kind of findings arose from this work, and they've been summarized in a report. But some notable feedback that we received from the students included like how much they enjoyed the opportunity to complete part of their PhD work in Canada, how they found it challenging to get peer reviewers and actually like publish in a field that is as niche as knowledge translation, how they would have benefited from more protected time during which they are actually paid to do their thesis work and nothing else, and how much they appreciated the opportunity to network with other scholars and the wealth of opportunities that they had access to as a result of being a part of this PhD. And for these 5 students, they also kind of documented 15 peer review papers, 12 publications that were kind of considered gray literature, presentations, additional projects to build KT capacity, and projects where they got to kind of consult on relevant health legislations. We also identified some more abstract outcomes of the program. As I've come to summarized here, the students who were part of this training program kind of agreed that they gained a lot of confidence, got insight into how KT can be applied to other aspects of their professional careers, how they developed skills to conduct and inform policy making in their respective countries. And in the blue box there, for the KT field at large, that training program essentially fostered a new generation of knowledge translation experts. These students became highly sought after by decision makers in their respective health systems, and they're invited to be lecturers and panel experts in international policy conferences and other projects. And as a result of their work, policymakers actually came to expect the use of evidence and proactively seek out research to inform their decision making. And that's kind of a complete reversal from the environment that these students were starting out in. Like less than a decade ago, these same students were knocking on policymakers' doors and trying to introduce this new framework and this radical concept of knowledge translation. The thing that I guess stood out to me most about this training program that I thought was kind of interesting was that although it was originally designed to be a regular 4-year PhD program, as of 2018, none of these students have yet graduated, meaning that some of them have been working towards this diploma for 7 to 10 years. And that's rather unusual, right? And kind of begs the question, what's keeping them from wrapping up? So after kind of talking to them, I quickly realized that the answer is that they simply were overcommitted. In a region with relatively low capacity to do knowledge translation work, it was simply too hard to focus on writing their doctoral thesis when so many cool opportunities to actually apply that knowledge is kind of arriving at their doorsteps. So for them, it's ultimately this dilemma between pursuing an academic title or doing their part in actually doing that work in strengthening the health system of their home country. And of course, they would choose the latter out of a sense of duty and passion for this kind of work. So where do we go from here? Obviously, students can't be PhD candidates forever. Many of them are expected to graduate within the next year or so, they obviously need strong support systems in order to accomplish that. Additionally, Sorry, that was the first box I forgot to click. But additionally, the fact that these students were so overwhelmed in the first place means that we need to continue funding capacity building projects in knowledge translation and potentially do this work also outside of health systems as well, thinking about social systems and other kinds of systems. And finally, the training program is not perfect and requires tweaking if future iterations are to occur. And it's up to the funders, the supervisors, administrators, and evaluators like myself to ensure that future programs are kind of created with in mind the lessons that are learned here. So to me, the kind of revelation that I reached through doing this evaluation work is that knowledge translation isn't just the set of tools and mechanisms like rapid response synthesis or stakeholder dialogues. It's actually an active area of research that is evolving and adapting to shifting needs of the health system. And I learned that there were incredible and dedicated humans behind that work who also weren't just academicians, but advocates and pioneers and game changers. Yeah, I wish I kind of had more time to share with you guys. Sorry, that picture was also not supposed to be clicked, but I wish I had more time to share with you guys the other aspects of my journey, because although my work with REACH was a key part of my learning, I also had the privilege to become involved in other projects that challenged me and shifted my thinking about global health and health systems. From shadowing a BBC documentary team to follow a story about how Ugandan school children are being taught to critically assess health advice before following them, to attending stakeholder conferences and sitting in the same room as powerful politicians and decision makers in health, to accompanying a university administrative team on site visits to other universities in other parts of the country. I was really, really lucky to have gotten glimpses of health systems and education systems in Uganda through totally unique and unexpected lenses. And at the end of the day, what made it hardest to leave Uganda was the people. Every single person that I connected with, from the folks in my office, to the staff at the guest house, to the drivers and restaurant owners that knew me as a regular by the end of my trip, they were also open to kind of let me into their lives, and I think their friendship is ultimately what made this experience really, really unforgettable for me. And that's kind of all I had, so thank you guys for listening.